Good morning, friends and colleagues. I am Dr. Anil Parikh, Medical Director, IPCA. It's a great pleasure for me to welcome all the medical fraternity who have joined for this first meeting of the Indo-European experts. The European Society of Hypertension has just released the 2023 guidelines, and this year is auspicious because this complete marks 20 years of ESH guidelines. And to learn about them, it's a very extensive treatise, and I found after going through all the guidelines over the years, from the American guidelines to the WHO ISH guidelines, this year's European guidelines is probably the most comprehensive document and covers a wide area of not only hypertension but also internal medicine, nephrology, endocrinology. So very extensive document, and we have a galaxy of European as well as Indian experts to help us decipher the whole guideline. It has been always been endeavor of IPCA to bring both international experts as well as the Indian experts since in our chosen areas of field, and we organize CME activities. This started in hypertension in the year 2011 when we brought Professor Aram Chobanian as the first expert who was the chairperson of the Joint National Committee 7 guidelines. And then we had Professor Henry Black and also Professor Franz Messerli. And throughout this journey, we are very fortunate to receive the guidance from Professor Venkatram, who has been always guided us. For today's program, we have two chairpersons. One from the Indian side, we have Professor Jamshed Dalal. So I'd request to put Professor Jamshed Dalal's slide on display. Professor Jamshed Dalal is the director cardiac sciences, Kokilaben Ambani Hospital, and he has been an extensive experience in interventional cardiology. But not only interventional cardiology, he has also been, I think I'll share my slide so that his slide is not brought. I'll just share his slides. He has very extensive experience in interventional cardiology and set up interventional cardiology not only in Kokilaben Ambani Hospital, but also earlier with other hospitals like Nanavati and Hinduja hospitals as well. And one thing is that although he's a prolific interventional cardiologist, he is also takes a huge interest in preventive cardiology. And whenever we ask him to come to the CME programs, we always find he is very, very helpful in this regard. Incidentally, the first meeting on low-dose chlorthalidone with Professor Aram Chobanian was chaired by Professor Jamshed Dalal. And now I would like to also introduce our next chairperson, who is also speaker, Professor Grassi.
Yes, good morning, everyone. It's my pleasure to have you on this web. I think that European Society of Hypertension and India colleagues have joined several other times in the past, and recently during the European meeting on hypertension, which was held in June, we had a wonderful joint session, and I think that today we will have another opportunity to have interaction with Indian research and missions, and therefore I am pleased to have this meeting with you. Thank you for your attention.
So Professor Grassi is Professor of Internal Medicine and Clinical Medicine, University of Milan, Bicocca, and he's Director of the Clinical Medical Institute. And he is the Vice Chairman of the 2004-2006 of the Working Group on Hypertension with heart of the European Society of Cardiology. And he has occupied various positions, has been in the task force of European Society of Hypertension for guideline on hypertension, and has been member scientific council of the International Society of Hypertension. And I think today he's going to update us on the beta blockers have been brought back in a massive way in this guideline. Although beta blocker has been relegated with earlier US guidelines and all that, but this ESH guidelines have brought back the beta blockers, and it is of particular interest that various uses of these beta blocker in hypertensive patients have been shared by them. And then we are very fortunate that Professor Venkatram is going to this session, and everybody knows Professor Venkatram. So Professor Venkatram has been associated with hypertension, so he has devoted his entire life to hypertension research and hypertension management, and we are very fortunate that we have with us Professor Venkat S. Ram to guide us further. And I think he's going to moderate today's session, so I request Professor Venkat Ram to kindly say a few words and then start the proceedings.
Okay. Thank you. Thank you, Anil. If you can stop the slide sharing, screen sharing.
Yeah.
Yeah, thank you very much. Good morning, ladies and gentlemen. Good morning not only to the faculty and the organizers, but also a large number of Indian doctors who have already joined the program from different parts of the country on a Sunday. So it's a great program. It's a truly international program because besides the audience, we have faculty joining from Milan, from Berlin, and today Dr. Dalal from London. And then I happen to be in Dallas, so it is truly a good morning for me because it's really morning. So it's a wonderful, what happened is with this program, I'll tell you, Guido, you'll be interested in knowing why we are calling this ESH Comes to India. There is one small incident that occurred at ESH 2023 meeting in Milan. We had an Indian faculty member who was going to speak at ESH, and unfortunately, he did not get an appointment for the visa with Italian consulate for several months. He was going to get an appointment now in September or October, although he applied. So I said, if this has happened, maybe we should need to create a format where we can call it ESH Comes to India to overcome these kinds of unusual incidents. So that is the genesis, birth of this platform called ESH Comes to India. And it is a very timely meeting. Number one, of all the countries that all of you have interacted with, the interest in hypertension is very much alive in India. They still have a lot of interest in hypertension, academic research, a lot of interest in listening, etc. That's one. And the other thing is the guidelines will be published probably next month or so. And even when they are published, not many people will read the whole document, at that time. And that is the reason why we thought we'll start a series of meetings, monthly meetings. And today is the first meeting, and I will make announcement of the next meetings, etc. Let me then show you the little bit of these guidelines. And by the way, the Europeans who are participating in this meeting, they are all leaders in the European Society of Hypertension from its beginning, from its foundation, and also from the guidelines. So you're really talking to the people who have contributed immensely to our current science of hypertension. Let me show you the slides. ladies and gentlemen, when I got a call from Dr. Reinhold's office to review the guidelines that are going to come, they did come, and I opened my computer, and then it was 200 pages document and 2,000 references. In fact, 1957 references. I said, I cannot read these things on the computer. I'm sorry. I'm okay, maybe 3 to 4 pages, but not going, and you have to go back forth and forth. And in fact, when I opened the guidelines, these are the 2,000 pages, 200 pages of the document and references. So I took a particular care to read as much as possible. Every day I was reading 50 to 60 pages and making a lot of remarks because they needed some advice. So it's very interesting that how these guidelines, a very big document, as Dr. Parikh has mentioned, it is a very, very comprehensive document, and it is going to be an enduring document for time to come. I can tell you right now to people in the audience that American College of Cardiology and American Heart Association have just started last week forming a committee for their new guidelines. So it's going to take some time. We don't know what is the timeline, but they just made an announcement, obviously triggered by the publication of ESH, because I know for sure until 4 or 5 months ago, there was no talk of ACC-AHA guideline. This is kind of a triggered, I think it's a good trigger by the release of the European guidelines. So, ladies and gentlemen, we're going to have a great meeting, great series of meetings throughout the year with the European Society of Hypertension, who are pioneers in hypertension. And with those remarks, with this introduction, let me hand over the program to Dr. Grassi and to Dr. Dalal to conduct the proceedings. Guido, I think you are going to start the program by introducing the speakers, and then Dr. Dalal, please proceed.
Venkata, thank you. I think that I already made my opening remarks. Again, it was really a pleasure, and it's really a pleasure to have you all from India for this joint meeting. And I think that the focus on guidelines will allow to improve the applicability of European guidelines in several countries. Thank you again for the invitation.
Okay. Can somebody show Dr. Krutz's brief bio from your side, and also Dr. Manchia's bio from your side, and then Dr. Krutz will start the program with his talk, if it is possible, please. No, not his talk, his bio.
Please show introduction slides.
Yeah. Okay. Now
Dr.
Go to
Krutz.
Dr. Krutz. No. No, next. Dr. Krutz, please. I think a slide is probably missing. Maybe Dr. Venkataraman, somebody could introduce them directly.
It's the next slide.
Next slide, please. Yeah, that's it, please. Dr. Grassi, please go ahead and introduce himself.
Yes, it's my pleasure to introduce a well-known clinician and researcher, Professor Kreutz. He's full professor of pharmacology at the University of Berlin. He was immediate past president of the European Society of Hypertension. He had several important achievements during his career, and the most important, most recent one, he is co-chair with Professor Mancia of the new European, of the Committee for the new European Society of Hypertension guidelines on high blood pressure. Therefore, it's my pleasure to have to introduce his lecture, Recommended Blood Pressure Goals in the General and Specific Population. Reynold, please.
Well, good morning, dear colleagues, dear friends from India. It's a great pleasure and honor for me to join our ESH president, Professor Grassi, and the chair of our guidelines, Professor Mancia, this morning, and to talk about the recommended blood pressure goals in the general and specific populations. Let me start with this slide, a recent paper from Professor Braunwald from Harvard, from Brigham Women's Hospital. And I'm starting with this because I think there's now some ongoing discussion and confusion talking about targets and blood pressure goals and confusing prevention versus intervention. And this is depicted in this slide when Professor Braunwald is talking about primordial, or you may say primary prevention in cardiovascular disease to avoid or protect against atherosclerotic cardiovascular disease. There are certain aspects, including hypertension or blood pressure, indicating supporting a blood pressure below 120 and 80 millimeter mercury. However, some colleagues miss to read actually the paper he is quoting, which is actually this paper by Dr. Donald Lloyd Jones in 2010, American Heart Association scientific report talking about primordial cardiovascular prevention. And this is referring to ideal cardiovascular health, a concept that is well supported in the literature. And it is defined by the presence of both ideal health behaviors, meaning quitting smoking, or do not smoke in the first place, a low body weight, healthy diet, the DASH diet or something like less, and ideal health factors, untreated blood pressure. Untreated blood pressure below 120, 80 millimeter mercury for prevention. It's well known in this landmark study from Dr. Sarah Levington in The Lancet in 2002 that in observational epidemiology, there is an increased risk to die from stroke, and the same applies to ischemic heart disease, not shown in this slide. This is for stroke. According to age in adults older than 50 years, with incremental increase of blood pressure, systolic starting from 150 and diastolic starting from 75 millimeter mercury. However, we have to differentiate between observational epidemiology, and we did this in the guidelines, compared to evidence-based treatment or intervention. Therefore, we have a definition of hypertension in most countries worldwide, and the threshold for treatment that are set at blood pressure values of 140 over 90 millimeter mercury, based on the evidence from outcomes obtained in randomized controlled trials. So we have an operational definition. That's important when we discuss about treatment and targets. Hypertension is the level of arterial blood pressure at which the benefits of intervention exceed those of inaction. So we keep the definition of hypertension and the threshold for drug treatment initiation in our 2023 guidelines at the level of 140 over 90 millimeter mercury. And this applies to most patients also for drug treatment initiation, most adult patients 18 to 79 years. Now, the question is to which targets I would like to discuss. So in 2018, regarding the office blood pressure targets, and everything is based on office, what we are talking now, because that is the evidence for office blood pressure. The first objective was, in the 2018 guidelines, to lower blood pressure below 140/90 millimeter mercury in all adult patients. If drug treatment is well tolerated, we may target to 130/80 or lower in most patient groups. Treatment, however, should never target blood pressure values below 120/70 millimeter mercury because 3 reasons. There's no consistent evidence that there's an incremental protective effect. There's also a signal that may even introduce harm, and also an increased risk of side effects if you lower to very low blood pressures because of treatment discontinuation or resulting in treatment discontinuation, and therefore also a rebound increase in events. Just regarding the issue of introducing harm, we know particularly in patients at high cardiovascular risk or high risk, such as in the on-target transcend studies, when you look at the hazard ratio for the primary outcome and achieved systolic blood pressure and diastolic blood pressure, you see this kind of J-shaped curve, where the risk for the primary outcome increases if you lower the blood pressure below 120 systolic or below 70 millimeter mercury. Whatever the reason is, it may be due to reduced organ perfusion or to overdosing or polypharmacy and treatment discontinuation, rebound effects due to that, as I mentioned, or reverse causation. It's an observation which is very important, I think, for us. We cannot ignore. Now, I like this study and slide very much from Professor Mancha, supporting the targets and the recommendation for the targets. When he looked with the colleagues from the value trial, in the attained blood pressure values, separated into deciles in the value trial, and looked the relationship, analyzed the relationship between the achieved blood pressure in the trial with regard to the primary endpoint, and several other endpoints are listed here. And they compared the risk as compared to those patients with the highest decile blood pressure during the trial achieved. So basically they had maintained high blood pressure, which was the reference 166/94. And then it turns out that when you look at the 5th and 6th decile and below, is shown here, it basically starts at a blood pressure level of 140/80, let's say 80 and below. You see that there's a profound protective effect if the blood pressure is lower compared to the reference in the value trial. But however, when you reach 140/80, the incremental protective effect is diminishing or fading away for all outcomes, even maybe increase when you look into all-cause mortality. So this is a very important message. The major benefit is achieved in this trial and in several other trials when you lower the blood pressure below 140 below and 80 millimeter mercury. And therefore, we try to visualize this in the guidelines with this graph. So the target is the green section, and the blood pressure level you should avoid is the red color, indicated by the red color. For diastolic blood pressure, the primary goal could be in the range below 80 millimeter mercury, because a meta-analysis by Tomopoulos, Parati, and the late Professor Zanchetti indicated, and several other studies, such as the value analysis, have shown that if you lower below 80 millimeter mercury, you have a major benefit and a greater benefit as compared to lowering between 18 and 89 millimeter mercury. So this is a primary novel recommendation to lower diastolic blood pressure as much as possible below 80 millimeter mercury in most of the adult patients. It's a little bit different for systolic blood pressure. The primary goal is still to lower below 140 millimeter mercury into the 130 millimeter mercury range. However, if drug treatment is well tolerated, the treated SBP values should be targeted to 130 or even lower in most patients up to 79 years old. And for the same reasons I mentioned already, in the 2018 guidelines, a low blood pressure below 120 systolic and 70 millimeter mercury diastolic should be avoided for the reasons I have shown already. However, there's evidence that the advantages to lower the blood pressure below 130 does not apply to several clinically important subgroups, such as patients with LVH, CKD, or isolated systolic hypertension in the elderly. I will discuss this later. In patients at least 80 years old, so the octogenarians or older, we may also be a little bit more cautious, particularly in those who are frail. However, if they are not frail and the treatment is well tolerated, we may also lower in older patients blood pressure below 130 millimeter mercury, and in very frail patients, and we have details about this we may discuss later on the subsequent sessions. In very frail patients, we have some guidance how to deal with them together with Professor Athanasios Benitos, who is a geriatrician and an hypertension experts, reported in the new guidelines. So just an example, LVH. We know in LVH, there's a marked activation of the tissue renin-angiotensin system in the heart and cardiovascular and cardiac remodeling ongoing in these patients, leading to hypertrophy, but not only to hypertrophy, but also to fibrosis and poor microcirculation and impaired coronary blood flow. And there are at least two important reports that there are poor outcomes in treated hypertensive patients with LVH that achieve a low blood pressure below systolic 130 millimeter mercury, a previous one from the LIFE study, and a novel one, a very recent one from the VALUE trial, reported by the team of Professor Schjelzen from Oslo. And they looked at 13,803 patients in the VALUE trial and almost 2,500 patients that had, based on ECG, left ventricular hypertrophy. And when they looked into the outcomes, comparing patients that achieved a systolic blood pressure below 130 millimeter mercury with LVH in red and without LVH in blue, achieving a similar blood pressure around 125 millimeter mercury systolic. Looking into the primary cardiac endpoint, you see those with LVH in red, no benefit, no reduction if you lower the blood pressure below 130, while cardiac mortality is almost doubled, twofold increased, and all-cause mortality is also increased, while those patients without LVH achieving the lower blood pressure have a benefit with regard, particularly for the primary cardiac endpoint, which is very important. So at least some caution is warranted in patients with LVH based on this study. Just another example from our study in Berlin, community dwelling older persons, actually relatively fit, included at the age of 70 years. The mean age is 81 years. And when we looked in those patients that had their blood pressure normalized below 140/90, taking blood pressure lowering drugs, you see there's an unfavorable effect. There's an increased risk for mortality, 26% increase of risk to die, particularly in those older than 80 years and with a previous cardiovascular event. So elderly, very old patients, octogenarians or older patients, and LVH patients, just two examples where some caution is necessary. So let me detail the office blood pressure targets for drug treatment as reported and recommended in our guidelines. The younger patients, 18 to 64 years, the primary goal is to go even lower, below 130/80 millimeter mercury with the 1A recommendation. Patients 65 to 79 years, the primary goal is to below 140/80, as I mentioned, for the overall population. However, lowering below 130/80 can be considered, it's a 2 recommendation, class of recommendation if treatment is well tolerated. So another important subgroup is the patient group with isolated systolic hypertension in the older persons. The primary goal here is, based on the evidence, to lower in the 140 to 150 millimeter mercury range. However, there are recent meta-analysis done by Kostas Tomopoulos and Matthias Grundström also supporting to lower the blood pressure below 140 millimeter mercury, even if the blood pressure is already low, diastolic blood pressure in the 70 millimeter mercury range, because the systolic blood pressure is the primary goal to reduce risk in these patients. Very old patients, 80 years or older, office blood pressure should be lowered in the 140 to 150 millimeter mercury range, similar as to the other recommendation in ISH patients. However, also here, if blood pressure is well tolerated, we may lower in the 130 to 139 millimeter mercury range. So this is just the general recommendations and the recommendations according to age. There are some subgroup specific populations that I would like to mention. Finally, diabetes. Diabetic patients, particularly type 2 diabetic patients, the primary goal is below 130, 80 millimeter mercury, has not changed actually. And in CKD, actually, surprisingly enough, there's not so much support to go to a lower blood pressure. If we looked at it, and our expert, the kidney experts, looked into that, they actually formulated still the kind of conservative recommendation with 1A to lower blood pressure below 140 and 90 millimeter mercury. Nevertheless, they stated that the blood pressure can be lowered in most CKD patients, particularly the young and the patients with high albuminuria below 130 to 80 millimeter mercury. And also we have a chapter referring to the kidney transplant patients. So in summary, I think I would like to show you again this slide, because if you look at the different targets, it might be a little bit diverse or confusing. I think that the major and essential take-home message is still valid, given in this slide, that we may target in most of the patients to 130 to 80 and lower, if well tolerated below 130 systolic, and below definitely 80 millimeter mercury diastolic. With this, I would like to end my presentation, and thank you very much for your attention.
Venkat, I think that we can go on. We will have the possible questions at the end of this presentation, and therefore I am pleased to introduce you Professor Mancha. He's very well-known clinician and researcher, and he's past chairman and chairman of the European guidelines, the present guidelines, and past president of European Society of Hypertension, International Society of Hypertension, and therefore I am pleased to give his presentation, recommended pharmacological choice for the treatment in the European Society of Hypertension guidelines 2023. Please, Professor Mancha.
Thank you very much. Thank you very much for this kind invitation. I appreciate it very much. And I will start from the main point made by Professor Kreutz. That is that according to the recent guidelines of the European Society of Hypertension, target blood pressure should be below 140 millimeter mercury, quite often below 130 millimeter mercury, exceptions he mentioned, with due consideration to tolerability of treatment, and diastolic blood pressure below 80 millimeter mercury, and never try to actively go below 120 over 70 millimeter mercury. But the point I have to discuss is how shall we reach these values? And the guidelines of the European Society of Hypertension give what I believe is a clear algorithm of what doctors should do. each candidate to antihypertensive treatment, which is people having value equal or above 140 millimeter mercury systolic and 90 millimeter mercury or 90 millimeter mercury diastolic, they should have correction of inappropriate lifestyles, because this helps in reducing blood pressure, few millimeter mercury, but this can be important and may facilitate the antihypertensive effect of antihypertensive drugs. But then most hypertensive patients also need drug, and according to the European guidelines, treatment should be instituted in most cases simultaneously with the institution of lifestyle changes. There is only one exception according to the guidelines, and this is individual with a very mild blood pressure elevation, grade 1 hypertension, but close to the threshold of grade 1 hypertension, and low cardiovascular risk. And in this case, physicians can afford to keep the patients only for a few months, only under lifestyle changes to see whether this is enough to control blood pressure. But after a few months, 3 months, according to the guidelines, if blood pressure is not controlled, then antihypertensive drugs have to be also given. Now, which drugs should be used to this purpose? Now, let me remind you that the European guidelines over the years have only adhered to an important principle for antihypertensive treatment. That is that the protective effect of antihypertensive treatment is largely due to blood pressure lowering per se, regardless how it is obtained. And this carries an important implication, and this is that the greater is the number of antihypertensive drugs, the greater is the chance to achieve blood pressure control and find a treatment which is tailored to the patients. So having more effective drugs is a wealth for treatment. In particular, it is a wealth for antihypertensive treatment. Now, in the previous European guidelines, there have always been 5 drug classes regarded as major drugs to treat hypertension. That is ACE inhibitors, angiotensin receptor antagonists, diuretics, calcium channel blockers, and also beta blockers. Now, the message was the same in 2018 guidelines, but to be fair, it was a little bit ambiguous and not really very clear. If you look at the algorithm of the 2018 guidelines, you can see ACE inhibitors, angiotensin receptor antagonists, calcium channel blockers, and diuretics very clearly evident in the algorithm. Beta blockers were confined to a sentence, small sentence in the very last part of the algorithm. So easy to be, not to be considered. Now, this time the guidelines have made it very clear that there are 5 major drug classes to be used for the initiation and maintenance of antihypertensive treatment. And these are diuretics, both thiazide and thiazide-like diuretics. There is no evidence of a superiority of one versus another, so both types of diuretic can be used. ACE inhibitors or angiotensin receptor antagonists, calcium channel blockers, but also at the same level of the other drug classes, beta blockers. And the reasons which are taken into consideration by the task force of the European guidelines, well, are very clear. And ability to lower blood pressure is similar for beta blockers and other drug classes. And as I mentioned before, this is regarded as extremely important because most of the benefit comes from blood pressure reduction. Then there is evidence for beta blockers as a class that versus placebo, reduction in blood pressure associated with beta blocker use is accompanied by significant reduction in the risk of cardiovascular events, but individually in the risk of stroke, heart failure, and coronary artery disease and mortality. And also when drugs are compared to one another in randomized clinical trials, where in meta-analysis, beta blockers have come out as being equally protective in cardiovascular events or only slightly different from other drug classes. Then there is also evidence, and also recent evidence, that protection by beta blocks extend to major hypertension-related cardiovascular events, heart failure, coronary disease, and also stroke, that the problems of tolerability and safety have been by and large overestimated, that metabolic inconveniences, which can be there, are much less pronounced or even absent with some types of beta blockers. And beta blockers, which have been regarded to have a greater less effectiveness against the symptomatic organ damage. Well, also in this case, some types of beta blockers with some characteristics, for example, cardioselectivity or associated vasodilatation, can be effective on asymptomatic organ damage. But one thing which guidelines have emphasized has been the fact that beta blockers are associated with a very large number of specific indications. This is a paper we published together with Professor Kreutz and other colleagues just a year and a half ago, and it shows in how many comorbidities associated with hypertension beta blockers are given, have to be given. Now here you have 8 different comorbidities related to the heart, and they are classically recommended for beta blocker use in hypertension guidelines. Very well known to all of you: coronary heart disease, heart failure, aortic dissection, heart rate control, which is quite common need in hypertension because hypertensive patients with an increased heart rate are quite a few, and atrial fibrillation. But then we look at several other indications, specific indication, not only related to the heart, but also to the vessels or to non-cardiovascular diseases in which in real life beta blockers are given. And one of the sentences which has been used in the guidelines is that considering there's more than 40 other indications, this makes beta blockers a de facto important antihypertensive drugs. But then beta blockers also do not forget to mention all drugs which are still useful, specifically in a number of specific conditions. For example, mineralocorticoid receptor antagonist, loop diuretics, alpha-1 blockers, centrally acting agents. I don't need to remember you that in some specific conditions, these drugs are still a very useful addition to the pharmacotherapy of hypertension. And what it is also mentioned related to the recent discussion and publication on whether drugs should be given in the morning or the evening. Well, beta blockers take the position that there is no evidence of any specific advantage of giving drugs in the evening. And so the preferred administration of the drugs should be in the morning, which is also the classical timing of drug administration in major antihypertensive treatment trials. Then what the guidelines do is to discuss the context in which antihypertensive drugs should be given. That is the treatment strategies. And I come to the conclusion that there are several treatment strategies potentially usable for lowering blood pressure in hypertensive patients. And some of them are given the green light for the first time. For example, the polypill with or without aspirin, because of important trials, mainly coming from India, which have shown that the polypill is effective in lowering blood pressure together with the reduction of other cardiovascular risk factors. And renal denervation, we now have evidence from blood pressure-related randomized trials of their ability or the ability of this procedure, this intervention to reduce blood pressure. And then other older strategies such as sequential monotherapy, combination treatment by the classical step care approach. That is, start with one drug and add other drugs if blood pressure control is not achieved. But they reinforce what has already been said in the 2018 guidelines, that the time-honored step care approach has not reached any substantial result concerning combination treatment. And remember that combination treatment is the backbone of antihypertensive treatment, because only by giving more than one antihypertensive drugs can blood pressure be controlled in the majority of the hypertensive population. Well, I don't need to tell you that in many, many countries, I would say most countries, combination treatment is not frequently used. This is the region where I live, Lombardy, and these are data from the Lombardy database, the entire population of Lombardy, about 1 million people. And you can see here that this is a recent paper. It was published in 2021. Well, the majority of the hypertensive population in Lombardy is still on monotherapy. Only a minority makes use of combination treatment. So the long-time recommendations of guidelines to use combination treatment apparently is not effective. And for this reason, already in the 2018 guidelines, the recommended major treatment strategy was to start with 2 drugs, then increase the dose of one or the other drugs or both drugs if needed, and then go to triple therapy. And this is reinforced by the present guidelines, strongly reinforced, because it is mentioned that 90% of hypertensive patients can be controlled by combination treatment up to 3 drugs, and only a minority in relative terms can be regarded as true resistant hypertensive individuals. And what is also strongly confirmed and strengthened the use of single pill combination. Now, the reason is clear from many studies. I apologize for referring again to Lombardy database, but these are data I have at hand. You see here a comparison of what happened to patients starting treatment with 2 drugs and single pill combination. Well, you can see that 80% of the patients maintain the 2-drug combination, whereas those starting treatment with 1 drug over the following 3 years, at the end, only 1/3 moved to combination treatment, strikingly less than what is recommended by guidelines, that is 90% of the patients. Then there is evidence against, in this case from Lombardy database, the treatment discontinuation is much less in people starting treatment with 2 drugs compared to those starting treatment with 1 drug. And then there is evidence that single pill, and this is growing and growing, the treatment simplification, as it can be achieved by using single pill combination, well, favors adherence to treatment. You can see in this very nice study that non-adherence is clearly related to the number of drugs, or pills or tablets patients have to take every day. Now, there is also in the guidelines, however, great attention to new drugs. That is ARNI, SGLT2 drugs, and non-steroidal mineralocorticoid receptor antagonists. And these are particularly useful and important in a number of specific conditions. And one of the elements of novelties of the guidelines is to discuss treatment in a large number of comorbidities, which are very common, of course, because hypertension is very common, and so it's very commonly associated with comorbidities. More than 40, between 40 and 50 associations of hypertension with comorbidities are discussed in the guidelines, never discussed before, and you can never find previous guidelines doing this. In this condition, I forgot to mention that one of the elements of novelties, and I had to mention this, is that compared to the past, guidelines this time do not limit use of combination treatment to blocker of the renin-angiotensin system with calcium channel blocker or diuretics. But as you can see with the line unifying different drugs, there is the sentence, the statement that several other types of combination treatment can be used. And this is due to the fact that there are trials, not randomized comparison trials, but trials using sequentially different types of combinations, which have shown in the end that reducing blood pressure by these treatments lowers cardiovascular events. And we now have a number of different combinations in a single pill format, which was not the case in 218. And 218, very few combinations other than a blocker of the renin-angiotensin system with the diuretic or with the calcium channel blocker was available in a single pill combination format. Well, let me now come to the final part, and this is very quickly attention guidelines to new drugs, ARNI, SGLT2, and non-steroidal mineralocorticoid receptor antagonist. I will make only two examples. One is treatment of chronic kidney disease, which is a very complex treatment, and chronic kidney disease, as you know, is very frequently accompanied by true resistant hypertension. You can see how different can this be, and more complex in this case, from the treatment of the general hypertensive population. Use of different diuretics in relation to the degree of renal damage, use of some other drugs in the context of the many drugs which have to be taken by people with chronic kidney disease and hypertension. And this is the point I would like to emphasize, also use of SGLT2 drugs, which have been shown to have a kidney protective effect, but also cardiac protective effect. And we have to remember that in the kidney, the major cause of death is due to cardiovascular disease. And even the use of non-mineralocorticoid receptor antagonists, such as finerenone, also showing the ability to protect the kidney independently on the blood pressure control. And the only, of course, caveat is that it does not have to be used with mineralocorticoid receptor antagonist, of course, not to duplicate the effect. But for SGLT2 drugs, one thing to remember also is that it does have the ability to lower blood pressure. And you can see that when this is studied by ambulatory blood pressure monitoring, when the reduction is 4 millimeter of mercury, about 4 millimeter of mercury, which for ambulatory blood pressure monitoring is not a small effect. And you can see this also in patients already treated with antihypertensive drugs, which is of course important because in patients in need of these drugs, other antihypertensive agents have to be used. And one other, and this is my second example, is treatment of hypertensive patients with heart failure. Not too many, because heart failure decapitates hypertension in most instances. But you can see how different can be the treatment of an individual with heart failure and hypertension, compared to the classical model I showed you before, there can be several drug combinations that have to be used in these patients. And what the guidelines emphasize is that in the not frequent case in which heart failure remains without blood pressure control, even calcium channel blockers can be used because they've been shown not to have an adverse effect on the heart under these conditions. And once again, SGLT2 drugs are extremely important because of the documented cardiac protective effect together with the renal effect. So one example of how different can be treatment of specific conditions compared to treatment of the general hypertensive population. And this is discussed in the guidelines, as I mentioned before, in detail, many conditions in which drugs to use and which strategies provide some advantages compared to other strategies. So I hope that if you happen to read the guidelines of the European Society of Hypertension, you will appreciate this. Thank you very much for your kind attention.
We now move on to the second and third and fourth presentations, and I'm going to introduce both the speakers straight away. We have Professor Gurpreet Wanda, who's going to be the last speaker. He's the Professor of Cardiology at the Dayanand Medical College and Hospital in Ludhiana in India. He's, as you can see, has published nearly 300 papers in various journals. He's the Director of Physicians Research Foundation of API, past President of the Association of Physicians of India, past President of the Hypertensive Society of India. He has been awarded the BC Roy National Award in the year 2006. He is the Associate Editor of JACC and the Chief Editor of the Postgraduate Medicine textbook. He will be talking in the last session on the applicability of the ESH 2023 guidelines for India. And I think that will be very interesting. Professor Grassi, who is the next speaker, has already been introduced. He's a part of the guidelines for 2023. And he's going to talk about a subject, I think, which is going to be quite extensively discussed, especially in India. And that is the rationale for the renewed upgradation of beta blockers in the treatment of hypertension. So Professor Grassi, over to you for your presentation, please.
Okay, thank you. Well, thank you again for the invitation. Well, my presentation will be focused on beta blocking agents, the past and the present by current guidelines. And the purpose, as Professor Mancia mentioned in his presentation, the position of beta blocking agents in hypertension was quite clear in the past. In the past was a first choice treatment of hypertension. More recently, particularly in 2018, beta blocking agents were removed from first steps treatment, and they were confined to specific indication or specific clinical condition. I think that the position, as I mentioned, was quite changed. This is an example that already mentioned Professor Mancia in his presentation regarding the 2018 guidelines, and this is the actual position. Therefore, beta blocking agents, like the other 4 drugs classes, are recommended for blood pressure lowering treatment in specific and more general position. You can see here on the right that beta blocking agents, this is the recommendation from last guideline, can be used as monotherapy at any step of combination therapy, therefore a wide use of these agents. And again, there are selected disease and conditions for the use of beta-blocking agents in patients with comorbidities on the left, or in several other conditions, more than 50 clinical conditions, therefore meaning that there is potentially a huge opportunity to use beta-blocking agents in hyperpressure treatment. I will show you with you some evidence regarding the importance of beta-blocking agents and the evidence that given this class of drug as first choice in the last guidelines. Well, there is a quite clear background for the use of beta-blocking agents in hypertension. It is to say the activation of the sympathetic nervous system. You know very well that beta-blocking agents are effective in reducing excessive overdrive of adrenergic tone in hyperpressure and in other conditions such as, for example, post-MI or congestive heart failure. But you can see in this slide that the sympathetic activation, which is the background for the use of beta-blocking agents, is present initially, in the initial form of hypertension, even in pre-hypertensive condition, and it becomes more and more evident through the elevation of blood pressure from borderline to mild to complicated and severe hypertension. And finally, there is strong evidence that resistant hypertension is characterized by very pronounced sympathetic overdrive. And this has been shown in different studies. These are our own study looking at the sympathetic overdrive in different hypertensive state as compared to the normotensive condition. And you can see here the clear-cut sympathetic activation in this condition. And one other issue, which has been mentioned quite clearly by the European guidelines, is the fact that when you have elevation in heart rate, you will have frequently a sympathetic overdrive. Well, guidelines put as cutoff for defining heart rate elevation 80 beats per minute. This is both clinic or 24-hour monitoring of heart rate. Why this threshold? Well, clearly because if you have people with more elevated heart rate, greater than 80 beats per minute, you will have greater chance to have sympathetic overdrive. And this has been shown by plasma norepinephrine levels or by sympathetic nerve traffic measurement via microneurography, as compared to the condition in which heart rate is lower, 80 beats per minute. Therefore, presence of heart rate levels greater than 80 beats per minute frequently means sympathetic overdrive, and therefore provide evidence for the usefulness of beta-blocking agents as agents capable to reduce the adrenergic activation and concomitantly or throughout this mechanism to reduce blood pressure levels. Well, there are also questions related, obviously, during for the past guidelines related to beta-blocking agents. But I think that the evidence for the use of these agents, like other antihypertensive agents, comes from a series of evidence. This, for example, is the very well-known low meta-analysis of about more than 300 randomized trials looking at the effects of, as you can see, different antihypertensive agents. Beta-blocking agents are shown in orange, and you see quite clearly that half standard, standard dose, or twice standard dose of different hypertensive agents provide blood pressure reduction, both systolic and particularly diastolic reduction, similar for beta-blocking agents and for other antihypertensive drugs. And this has been shown looking at the possibility that reduction in systolic blood pressure particularly may allow to obtain a number of favorable effects by reducing stroke, coronary heart disease, heart failure in general, cardiovascular death and all-cause death, therefore again stressing the importance of blood pressure lowering effects of beta-blocking agents and in general of antihypertensive agents. And this has been again shown by a meta-analysis by Tomopoulos and Professor Rizzacchetti looking at the effects of different antihypertensive agents or a composite cardiovascular mortality and morbidity in hypertensive treatment as compared to placebo. And you can see here the very clear position of effective beta-blocking agents as compared to other antihypertensive agents in producing these favorable effects. And in general, the comparison between beta-blocking agents and other treatment on cardiovascular outcomes and mortality, which has been provided by a number of clinical trials, clearly show the favorable effects of, with some difference between trials of the beta-blocking class of drugs. This is a quite clear example. These are the ability of beta-blocking agents as compared to ACE inhibitors in UK PDS, looking at the more probably favorable effects of beta-blocking agents as compared to this class of drugs, particularly for myocardial infarction and microvascular disease. Therefore, no question of the ability of cardioprotection exerted by antihypertensive agents, and particularly by beta blockers, as compared to other agents such as calcium channel blockers, blockers of the renin-angiotensin system, and all other class of blockers. You can see here the similar potential favorable effects of these antihypertensive agents. There was a caveat related to the use of beta-blocking agents and the risk of stroke as compared to other agents. You can see here the different meta-analyses and studies showing an increase and not a reduction during beta-blocking agents as compared to other agents in protecting stroke events. And there are a number of factors which may be responsible for these not so favorable effects of beta-blocking agents. Probably one of them is the potential adverse effects of beta-blocking agents on cerebral blood flow auto-regulation, but also the evidence that the blood pressure reduction in some of these trials was greater for the other drugs as compared to beta-blocking agents. And this was the conclusion of the 2018 European Society of Hypertension and European Society of Cardiology guidelines, showing that beta-blocking agents may provide a less effective protection as compared to other agents, and this may be responsible for the blood pressure reduction and probably for the central blood pressure effects not favorable of beta-blocking agents. There has been mentioned the combination treatment, which is highly recommended in new guidelines, and you can see here that we have in different trials a clear-cut experience of the beta-blocking agents associated with diuretic, calcium channel blockers, or ACE inhibitors in providing blood pressure control and a reduction in cardiovascular events. And therefore, this was the conclusion of which has been reinforced by the latest European guidelines of hypertension, recommending the use of beta-blocking agents in combination with other drugs in antihypertensive treatment. We know very well that Professor Mancia mentioned the potential side effects of some beta-blocking agents, which depends on a variety of factors, metabolic effects, but also the characteristics of different beta-blocking agents. We know very well that there is a wide range of beta-blocking agents capable to have different effects as far as cardioselectivity, vasodilation, and duration of action. And therefore, this means that for specific conditions, we have the possibility to make the right choice for employing beta-blocking agents. This will be one of my last slides related to a nice paper published years ago looking at the potential favorable effects in hypertension, not only to reduce blood pressure, but also to have heart rate control. You can see here the cumulative primary events looking at the different effects, controlling only blood pressure, controlling also heart rate, therefore lowering blood pressure and heart rate. You can see here that in this specific case, the combination of blood pressure control together with heart rate control provide a greater cardiovascular protection. And this is, I think, is again a nice example of the opportunity to use beta-blocking agents, particularly in specific clinical hypertensive phenotype. This will be my last slide, which refers to a paper already mentioned looking at the drug class potentially used first choice combination treatments for hypertension. And this has been again stressed and well documented by latest European guidelines, putting beta-blocking agents with the other class of antihypertensive agents for the treatment of hypertension. Thank you very much for your attention.
Thank you, Dr. Grassi. We'll now move ahead with the last presentation of Dr. Wonder, and he'll be telling us on how the new guidelines will affect management in India. Over to you, Professor Wonder.
Thank you, Dr. Jamshed Dalal, and thanks to Dr. Venkatram for giving me this opportunity to speak to you as to what all lessons can be derived from these latest guidelines, the ESH guidelines, which have come just a couple of months back. We all know the last guidelines that came were the International Society of Hypertension guidelines. Our own guidelines are now 4 years old, and they are due for a new version to come for the next year. So let's see what are the lessons from these very highly evidence-based guidelines that we are talking of. Being the last speaker in after such architects of European guidelines does have some handicap, but it has a significant advantage. Because as you see, we've heard Dr. Reinhold talking about the targets and the threshold for starting treatment. Dr. Mancia told us about what drug choices we have. Dr. Grassi just discussed on the beta blockers. And so I will actually limit myself to some of the aspects which have not been covered because these are all three aspects have been very beautifully covered in these last hour or so. You all know in our country, the global burden for disease study showed us that whereas hypertension was responsible for 9% of deaths in 1990, this has increased to about 17%. And disability associated life years have also increased from 4% to it. So the bearing that hypertension has, we also know from the ICMR India study, which was published this year itself, that across the country, prevalence of hypertension today is actually 35%. Different studies give prevalence ranging from 28 to 35%. But this is the latest that we have in terms of how much, as a population is aging, average longevity of life today of an Indian is 67 and 70 years. You can see, and we all know, hypertension is actually a disease which is age-related, and the lifetime probability of having hypertension in an 80-year individual is 75%. So you can see as the population ages, the prevalence of hypertension goes up, and this is partly responsible along with other factors in our own country. So what we are talking today has a huge public health bearing in terms of if we want to impact actually mortality and if we want to impact and produce good health to our middle-aged individuals. We know hypertension. This is an editorial which we published in the Indian Journal of Medical Research, Dr. Venkatram and I, and we did emphasize that hypertension occurs early amongst us. There was earlier a rural-urban divide, well, almost half amongst the ruralites, but that has been bridged because the rural India today virtually actually lives like the urban India. And so there is a rural-urban convergence of these various risk factors, and so also hypertension. We harbor syndrome X and some of these risk factors which the Europeans are talking. There is a clustering because we have central obesity, we have insulin resistance syndrome, and we have a male pattern of obesity in our country. And you all know the criteria for central obesity and also for obesity itself, the BMI is lower among South Asians as compared to other races. There is a significant variation because the part of the equator that India is located in, we have wide variation of temperature between summer and winter. And we all, as clinicians, we downregulate therapy in summers and we upregulate the therapy in winters. So these are some aspects which are peculiar to us, which you may not actually find that much of a mention in these guidelines. The average blood pressure in our population is rising. This is interesting data from the 2018 European guidelines where they, although we don't have our own scoring system, but South Asians actually a multiplication factor is, so if you are using the score system, the multiple will be 1.4, which is higher than actually all other races in the world. So we as such have target organ damage, coronary disease, effects of hypertension and other coronary risk factors much higher amongst us because of a genetic predilection of the thrifty gene, small children, all these factors that we have which result in actually a clustering of the ICMR study shows 11% prevalence of diabetes, 15% prevalence of pre-diabetes, obesity, especially the central obesity is increasing amongst us, and the peculiar dyslipidemia that we have of high triglyceride levels, low HDL, which actually in these hypertensive populations result in, these are in terms of numbers that we have. This is data which came a couple of months back. Hypertension in Asians is not the same as hypertension in Europeans. I need to emphasize some of the 2 or 3 of these important aspects. Morning blood pressure, nighttime hypertension are some of the factors which are well recognized amongst Asians. Besides the genetic predilection for target organ damage and coronary disease, for the same level of blood pressures as compared to Caucasians, that South Asians have higher prevalence and also higher. 10 years earlier, we have heart attacks due to hypertension. So all these factors are important. East Asians have a higher prevalence of stroke, while we have a higher prevalence of coronary disease. They also have higher prevalence of non-ischemic heart failure. These are some of the factors which have been highlighted in the International Society guidelines. Well, these guidelines are excellent guidelines. Only one thing I found missing in these guidelines is when it's mentioned hypertension and ethnicity, it's all about African migrants. Actually, there's no mention of South Asians, although today South Asian population forms a very large, and that's the reason actually we will now be bringing out our own guidelines, which are which came in 2001 around the same time as the ESH guidelines. The first ones came, and this is actually the definition of hypertension that we gave. The Europeans this year has really put things in its right perspective, because the normal blood pressure, as you were told, is 140 by 90. But the optimal is 120 by 80. and you keep adding 10 to the systolic in the normal range and 5 to the diastolic to move from optimal to normal to high normal, then keep adding 20 to the systolic and 10 to the diastolic to move from high normal to grade 1, 2, 3. But this is too well known to this august audience. Something that I really want to draw your attention is the stage. This is a new concept added. It's a new way of putting things. Stage, besides considering the blood pressure value, look at the complications of hypertension, the hypertension-mediated organ damage, other risk factors your patient is harboring, and the cardiovascular disease. Stage 1 is none of these when there are no uncomplicated hypertension. Stage 2 is those people who have hypertension-mediated organ damage or early CKD. And stage 3 is your patient has a stroke, patient has had an MI. So the risk of the individual will obviously be dependent not only on the level of blood pressure, and as has been emphasized in the latest ESH guidelines, it will also depend on the number of risk factors your patient has, the hypertension-mediated organ damage, and the clinical cardiovascular disease evidence that your patient has in an escalating manner, and your aggression or your, in fact, approach to management of blood pressure will obviously be that much more effective. This is another beautiful diagram that I found in the European guidelines. It kind of puts that besides the genetic factors, the lifestyle factors like diet, alcohol, smoking, physical activity, sleep is being given a lot of emphasis today. Lack of sleep causes more of these non-communicable diseases. Stress, environmental pollution that is very relevant to our own population. And they act through these some very well documented RAS, sympathetic nervous system, endothelin systems, but the ones which are more important in hypertension, some newer factors like the gut microbiota. So it kind of puts the mosaic theory of hypertension into its current perspective when we know that immunoinflammation is involved and those various factors are involved in inflammation. So I would like to draw your attention to this, and maybe you can go through this. We actually have seen in studies of trans-ancestry genome-wide association that DNA methylation has relationship. Now, these are polygenic diseases, but there are some monogenic factors also which cause hypertension, but that's a very small minuscule of these patients. Most of the hypertension is primary hypertension that we are discussing. Another beautiful diagram, well, you are already familiar with this in the ESH guidelines, but put it in a better way by these guidelines. Take 2 readings at home, take 3 readings in the clinic, and delete the first one, and then take the average of the others. Of course, the level of the blood pressure apparatus should be same as the cuff. Person should be sitting, should not have all these things. But all that I want to emphasize is these seemingly simple factors make a huge difference in terms of, so that you do not overestimate hypertension. And clinic blood pressure and home blood pressure is being discussed widely. We did this study in a very large number of patients, and we looked at the inter-arm blood pressure, which you must record whenever the patient comes to you first time. The arm with the higher blood pressure is the one which is to be recorded for subsequent readings, and this has been emphasized. It's a huge data of more than 134,000 patients published in Journal of Clinical Hypertension, and there is a 6% of people will be classified as hypertension, in addition to the ones if you are recording. So record blood pressure in both the arms, as has been highlighted. In elderly people, those with diabetes, autonomic neuropathy, multiple drugs, record their blood pressure in lying and standing. The blood pressure measuring devices are an issue of discussion today because the automated oscillometric devices have taken over the earlier mercury sphygmomanometer, the manual methods. We still use the aneroid sphygmomanometer, but today we actually are largely world over the automated oscillometric ones. They can, of course, be used with auscultation also. But these are the ones, because we all know India is a signatory to the Minamata Convention. The mercury sphygmomanometer is not to be used clinically, although the government of India is still in the process of removing them. But we should have done this a couple of years back, and I'm sure in the next 2 or 3 years, the mercury sphygmomanometers will no longer be available. And we need to develop in our country very well validated oscillometric devices so that our clinicians can depend upon them. We have been working on a material called gallistin, which is actually similar to mercury, so which does not have any environmental toxic effects. Hopefully, this will actually in the scientific reports we published, and now it's going for patent. But hopefully, these devices will come which you will be able to use manually. Another very big area which has been emphasized in the newer European guidelines, although it was emphasized in their 2018 guidelines, that home blood pressure makes patients participate. It also increases the patient's actually involvement in their treatment. It is not to be used for diagnosis, but it is to be used for long-term follow-up. And we need to use reliable, very important factor for clinicians. One should ask patients to monitor for 7 days, at least for 3 days. They should not react. Something that I find in my clinical practice, patients find one low reading or one high, they change the medicines. If you have to use home BP monitoring, tell them not to react to single readings. The first day's readings have to be deleted. All these points have been emphasized actually very beautifully in these guidelines, and we have to then calculate the average of this. This is a large Indian study, the India Heart Study, in which we actually, a lot of us actually here also, Dr. Dalal also was a part of it. And what we looked at is a large study of 18,000 patients in which self blood pressure reading was compared with office. And what we found actually in this study was that white coat hypertension in India is 14% prevalence, and masked hypertension, which carries almost similar prognosis as sustained hypertension, is 20%. So this is not something which is not relevant to our country. Home blood pressure patients need to be involved. And this actually we recently only published. We looked at physicians in terms of how much home blood pressure recording is being advocated. Only 1/3 of patients at present get this advice. And only 4% of us actually know what are the guidelines as to what 135/85 is to be taken as the criteria for diagnosing hypertension. Even the Asian home blood pressure survey was conducted, in which 8 Asian countries had participated. And similar to India, we found that the percentage of individuals who are actually using, so we need to go up on this, escalate on the usage of home blood pressure, and so that our patients get benefit. Having talked a little bit about the criteria for diagnosis, the definition, and the apparatus that we use, let's spend a couple of minutes on the risk stratification, because this has been beautifully shown in the latest guidelines. Of course, we know aging is a system. With increasing age, the vagaries of hypertension, the end organ damage with hypertension is more. As the blood pressure goes up, the target organ damage is more. But also important is, as the patients have hypertension-mediated organ damage, as they have more and more of it. So conceptually, we should keep in mind that if the patient has more risk factors, has hypertension-mediated organ damage, or clinical evidence, we need to be more aggressive. And that is what we actually, along with Dr. Venkatram and Dr. Rajiv Gupta, we published an editorial in which said, yes, although we do not have our own Indian score system, but these are the 4 factors: increasing age, male sex, higher lipids, smoking habit, of course, systolic blood pressure, and diabetes. These are the 5 factors along with the blood pressure value, which should tell you how effectively or how aggressively you need to treat your patients of hypertension. This is from the 2023 ESH guidelines. This is a factor which has been emphasized, and we were discussing beta blockers. There is data, and a lot of people, Dr. Jamshed Dalal just mentioned, a lot of us believe that the intrinsic sympathetic activity is a little bit higher amongst Indians or South Asians because of various immunoinflammatory factors. And in fact, some of these, the India Heart Study that I showed you, the heart rates of an average Indian were higher by 10 beats per minute as compared to other races. So people here, even when beta blockers had receded, at that time also Indian physicians were wanting to use beta blockers. So it could all be actually just the drug effect, because the LIFE study showed us that atenolol did not fare as good as losartan. but the Happy, the Mafi, and people now believe the newer beta blockers probably, they do not have the same effects, so it rather than a class effect, it could be a drug effect actually. These are other factors emphasized in European guidelines which actually relate with the risk. Low birth weight, frailty is a very important concept which we should keep in mind. Elderly, frail individuals, be less aggressive in your approach to treat hypertension. LPA levels are genetic risk factors which are higher amongst Indians as compared to other races. We as yet do not have drugs we can lower LPA levels, but the same level of LDL will. So all these risk factors have been emphasized in the latest European guidelines so that we can risk stratify our patients. Of course, you will try to look at what are the hypertension-mediated damage, whether it is left ventricular hypertrophy, albumin-creatinine ratio. These are usual actually factors which you will look at in terms of. This is a beautiful actually cartoon which has been shown in these guidelines. I'm not going to talk about this, but some of these secondary factors have been emphasized as to what is the prevalence and how you should go about. So as followers of resistant hypertension, as some of you who manage patients with complicated hypertension, this will surely be useful to you. This is the key slide from the European guidelines on treatment. As I said, I'm not dwelling upon treatment because treatment has been very well discussed by the three previous speakers. So this is something actually interesting. Indian physicians have always been using single pill combinations, although of late our government has trying to put some restrictions. But a quad pill, we have all been using triple drug combinations. But the new guidelines, the 2023, are actually saying that a quad pill which has quarter doses of 4 drugs and a phase 3 trial has been mentioned in these guidelines. So we are really actually in an era when we are using combination, fixed dose combinations so that we improve the drug compliance of our patients. This is the follow-up that has been emphasized. I just laid my hands on this. What impact do the new ESH guidelines have on the management of hypertension in Japan? This is this year. Yes, out-of-office blood pressure monitoring has been emphasized. I also have spoken about it. Morning doses, earlier the time study came last year, and now as Dr. Mancia was emphasizing, most drugs should be given in the morning. They have emphasized personalized approach because we recognize various phenotypes, and they were saying actually various subset of patients to which your given patient could belong. Telehealth, digital strategies, renal denervation is expensive in our country still, although now there is evidence coming. And this is data which came this year, and this is something that my last 2 or 3 slides in which I would like to emphasize. For Indian physicians, I am told a very large number of physicians are attending this this webinar. Although we earlier had 17% people who had controls, but even today, not more than 1/4 of our people have their blood pressures controlled. And so we need to develop our own strategies, whether it is greater task sharing, whether it is extended prescription periods, or whether it is involvement of staff nurses, apps. We need to develop our own strategies. This is something we emphasized actually along with Dr. Venkatram. He took me along, and we published this in Circulation, in which we emphasized in an editorial that hypertension screening and diagnosis programs on a massive scale need to be undertaken in our country if we have to reach and make this form of therapy available to a larger number of people so that we can make a public health impact. The European Heart Journal last time in 2018, Dr. Venkat and I did emphasize again that protocol-driven standardization of treatment regimens, kind of regimen that has been shown, the ABCD algorithm, the simplistic algorithm that we have, and it's a combination therapy. And I will end here with a very positive note, actually, that the Indian Hypertension Control Initiative itself has been started almost in now 9 states across the country, and better hypertension blood pressure controls are achieved in primary health centers, the general physicians, rather than the wellness clinics or the community health centers or the big hospitals that some of us work.
So the primary care physicians are, in fact, if we have to impact in terms of reaching to a larger number of people and controlling their patients, something like what Dr. Venkatram has made possible today, reaching out to a large number of general physicians so that more and more of our patients get treated. Thank you.
Thank you, Dr. Vander. Now we move on to Dr. Venkatraman for the final phase of our session today. Dr. Venkatraman.
Thank you. Thank you, Jamshed and Guido. The final session, it's going to be a compressed session, but it is going to be a very useful session because a number of people have participated. And I'm going to look at the chat box and I will select the questions as needed. Then I'll direct them and I'll also ask the panelists to comment. Let me introduce the panelists in their alphabetical order of their surname. The first panelist is Dr. Umapati Hegde. When they told me that Dr. Hegde is going to be a panelist, I was very much worried that it was going to be B.M. Hegde from Manipal. I was kind of scared. So it's good that it was clarified. It is Dr. Umapati Hegde, a very well-known therapeutic and interventional nephrologist from Nadiad, has tremendous experience in treating patients with hypertension with and without CKD. And he had a prominent role in the Indian Society of Nephrology, as well as the International Society of Nephrology, which has given him a fellowship to acquire additional training. And I'm really, really delighted that he is helping a lot of people with chronic kidney disease in an area that needs the most, Nadiad area of Gujarat. And we welcome Dr. Hegde to be a panelist.
Thank you,
sir. Second panelist is somebody whom I had known throughout my professional career, is Dr. Uday Jadhav. Uday Jadhav is a prominent preventive cardiologist in Asia. He's, of course, therapeutic cardiologist also, but he has made a role for himself in prevention of cardiometabolic diseases because he does believe that prevention is more important than the cure. And he is also able to correlate the structure-activity relationship in pathophysiology of cardiovascular disease. He did research on measuring intermediate thickness as a surrogate marker of atherosclerosis, and then subsequently tried to correlate it with the pulse wave velocity, the impact of atherosclerosis on the transmission of the pulse wave, etc. So he's a kind of a pathophysiology of cardiovascular disease, structure and function, which is very, very important. He has made major contributions to our understanding of hypertension and cardiovascular disease in India, and I am glad that he has accepted our invitation to play an important role in the panel discussion. And next is Dr. Kamal Sharma from Ahmedabad. He is a interventional cardiologist, therapeutic cardiologist, and also has interest in prevention of cardiovascular disease. And he is highly qualified in terms of his medical education and postgraduate education, and his current role at SAL Hospital in Ahmedabad, which, by the way, is one of very prominent private hospital care providers in Ahmedabad. He continues to show interest in hypertension-related cardiovascular disease. And I did not know that he was IAS and IPS. I did not know that he was IAS, remarkable person to have IAS and IPS. Well, retrospectively, I wish he had gone to IAS rule to make some proper regulations rather than the recent troubles we had with the administrators. So one thing I noted that he got 22 gold medals, and I calculated most gold medals are made up of silver, but the covering is gold. So I calculated 22 gold medals, let us say 6 grams of gold, that comes to 132 grams of gold. And at today's rate, that is 7.5 lakh rupees. So he's a rich man. He's a rich man gold medalist. So ladies and gentlemen, please join me in inviting our panelists to participate. What I will do now
Kind words,
is,
Doctor.
what I would like to do, in all fairness to the panelists, I would like the panelists to make one or two observations from the presentations that were made. And first I'll reverse the order. I'll ask Dr. Sharma to make one or two comments on what he has heard now. And then Dr. Sharma will hand over to Dr. Jadhav to make one or two comments. He will hand over to Dr. Hegde, and then we'll go to the discussion from the chat box. Kamal?
Yeah, thank you. Thank you, Dr. Ram. Thank you for having me on this elite panel. A fantastic meeting as always. When Dr. Ram is in the control of the meeting, he's the one organizing. Nothing short of this that you can expect. So thank you very much. Two important things. I will say the positive side. One, that I got the message was the beta blockers have got back in a big bang way. I'm very happy about it. I always believed in that they were unnecessarily punished for one or couple of meta-analysis driven primarily by atenolol, which actually gave bad repute to probably whole of the beta blocker as a class. Again, 2018 tried to rectify it to a huge extent, but now we have them in the full-fledged role and the good classification that has shown that all four can be used. What I am a bit disappointed I looked at was that we were moving from class-based therapies to molecule-based evidence-driven therapies. When we know that in beta blockers, it's one molecule which has given a bad repute to whole of the class. There are other molecules which have different pharmacokinetics, dynamics, receptor. Probably we are marching forward towards molecule-driven guidelines as we are moving towards individualistic therapy. We probably have to get individualistic also about the molecules. But I think we are progressing in that direction. But of course, it'll maybe take some time. But when we probably had this kind of a guideline coming in as a blanket call for all the beta blockers coming back in, probably that's where I probably thought that there may be some more light. Maybe the elite panel can throw some light on that aspect as well. That's my two comments. Thank you very much.
Uday?
Thank you, sir. Just a couple of comments. First is that the interest shown for the placement of sacubitril valsartan in patients of hypertension who are candidates to develop a heart failure with preserved ejection fraction. So in that category of patients of HFpEF, if sacubitril valsartan can be given a prominent place, I guess it may make a difference. We don't have clinical trial-based evidence, but it would be worth looking at it. The second quick comment is in the difficult to treat hypertension, whether we look at the renal denervation therapy, and for that matter, even the addition of spironolactone, it will be a while before we look at the class 1A indications. We'll require a CV outcome trial of real magnitude. I believe either for renal denervation or for spironolactone, that could run into thousands of patients. So it will be worth seeing what eventually gets into the class 1A indication. Those are my two comments. Thank you very much.
Umapati.
Thank you. Thank you, Dr. Ram, for the opportunity. As a nephrologist, we were using beta blockers as a third option or a fourth option, which again, we were afraid that the earlier guidelines, they deleted the beta blockers, that it is not going to have a mortality benefit. Now it has been included, it is good, because the kidney failure patient, they have more and more of sympathetic overactivity, which leads to water salt retention and even a renal angiotensin system activation, which is one of the culprit, and most of our patients die of cardiovascular diseases. So it's a major impact that the cardiovascular activity, which will be reduced by the beta blockers and ACE inhibitor ARBs, are the major part of antihypertensive things. And this guideline, SGLT2, have now has a major impact in reducing cardiovascular diseases and the retardation of progression of kidney disease, which also will have an impact around 3 to 4 millimeter reduction in the blood pressure. So addition is a good move. And at the multiple therapies, most of our CKD patients, they have resistant hypertension. because of the water salt that require ACE inhibitor if possible, and an AR calcium channel blocker and a diuretic. After that, the next most of our nephrologists uses centrally acting agents like clonidine or moxonidine, because their blood pressure effect. I know that the withdrawal will lead to more and more acceleration in the blood pressure, but most of the nephrologists are using clonidine. So, and even those who have more than 30 ml of GFR, you are using a spironolactone as the fourth agent in these patients.
Okay. Thank you, Umapati. So thank you, panelists, for your observations on the trial. I just want to make one comment for the audience. There was no time really to discuss the other choices that were shown in the European guidelines. RAS blockers, thiazide-like diuretics, calcium channel blocking drugs, they all have been retained to their original status. Nothing has changed with them. There were no new data. That is the reason why they still maintain their previous position in the choice of therapy, RAS blockers, mainly ARBs, and then CCBs. And this time they use the word thiazide and thiazide-like. They remain important as always. But because of the resurgence of beta blockers, there was a greater emphasis on it. But there has been no de-emphasis on any of the other choices that they have made. It's very, very important to know. So we'll go for a chat discussion. We're dealing with, I just looked at the UN data. We're dealing with 1.3 billion people in the world with hypertension, and 900 million people have uncontrolled or untreated hypertension. So nearly a billion people have untreated or uncontrolled hypertension. That means they're nothing but walking time bombs. They can have an acute or chronic complication anytime. Let me just go to the chat box, and then I'm not going to read some of which are repetitive. There is a question that among the diuretics, thiazide-like diuretics, whether chlorthalidone, which is a thiazide-like diuretic, is recommended for people with eGFR less than 30. I know Dr. Manchia has shown a chronic kidney disease slide. He can comment on it because it's therapy, and then I would like Dr. Hegde to comment on it, perhaps with reference to Dr. Rajiv Agarwal's study in New England Journal of Medicine. Giuseppe, you have any comment on chlorthalidone in patients with CKD, GFR less than 30? You're muted.
It may be surprising. I think it was surprising to me, but I think evidence is evidence. It was a paper published, the design was okay, and there was, I think we have to accept the data that indeed in people with advanced renal damage, renal disease, chlorthalidone was effective. I think this is the only answer. I think the guidelines are based on evidence. Just referring to the previous comment, you know, that class beta blockers as a class and atenolol was a bad beta blocker. Well, atenolol had problems. To me, the main problem is that in perhaps 30% of the patients, once a day atenolol doesn't cover the 24 hours. But I think when writing the guidelines, you have also to ask, where are the trials with other beta blockers showing that they are more effective than atenolol? And the answer is, with the exception of metoprolol, and this was a very old study, there is no evidence. So considering this, I think it's almost inevitable that although mentioning differences between beta blockers, you have to consider the class of beta blockers.
Okay, thank you, Gochev. Umapati, do you have a brief comment on chlorthalidone in patients with GFR?
Earlier, we used to use either chlorthalidone or thalidomide-like diuretics only if the GFR is more than 30. We're afraid that because the GFR goes down, it may not be effective in reducing the water and even the salt from the body. But the studies have shown light that even in less than 30 ml up to 20 ml also, it is effective in a combination. It reduces the blood pressure in more than 8 ml, 10 ml, so which is very good. Otherwise, we were used only a loop diuretics, and either a furosemide or a torsemide we'll be using more oftenly. So even chlorthalidone or thiazide-like diuretics, it works even in less than 30 to reduce because it excretes more of salt. So salt excretion is much better with thiazide-like diuretics. So the blood pressure in reducing the salt burden and in the water content, it will be helpful in the blood pressure control.
Dr. Venkatraman, we have for long been saying over the last few years that it is better to use thiazide-like diuretics and not thiazide. So now are we changing our thinking process and saying both are equal because we are now going backwards compared to, we brought beta blockers back in again, now we are bringing thiazide back in again without any new data. So what is changing now that suddenly we are bringing the old drugs back?
Yeah, what is, there is slight change, not much. A majority of smaller studies have used thiazide as a part of combination therapy. Very rarely diuretics are used by themselves. But when you look at the older studies like SHIP, Mr. Fit, and hypertension detection follow-up program, ALL-HAT, SPRINT, etc., they have used chlorthalidone for the outcomes, and the outcomes were positive. A recent study, which Jamshed, you know, the Diuretics Comparison Project has shown that thiazide and thiazide-like diuretics were equal in terms of cardiovascular protection. The only difficulty was that thiazides in that study were used for a longer period of time, whereas thiazide-like diuretics were used for a shorter period of time. So the question was whether the short-term exposure to thiazide-like diuretics is as good as long-term diuretics. So the choices are both are there. And Dr. Manchia has actually shown one slide, the vertical column, where thiazide-like diuretics were used in outcome trials. So right now, the question would be, they appear to be very, very similar. One advantage that Asia has, South Asia has, you have low dose of thiazide-like diuretic, like 6.25 or 12.5. And in most countries, it starts with 50, not even 25, 50, and that could be problematic. There is a question that I will answer in the interest of time. What does SPC stands for? Single pill combination. Now, there is a question about the role of SGLT2 inhibitors as antihypertensive drugs. Dr. Manchia has actually, I'm really surprised that it is mentioned in the recommendations. I've never seen in the recommendations SGLT2 inhibitors. This first time I have seen it.
But I think almost mandatory because the evidence is quite strong. It is strong also, not only because they lower blood pressure, no question about this, and the fact that the blood pressure reduction can be seen also in people treated with a number of antihypertensive drugs in a way is another plus. The mechanism still unclear, although probably reduction in blood volume because of osmotic diuresis can participate. But I think the evidence of protective effect on the kidney and the heart is there. And what is very interesting is that it is there in diabetic and non-diabetic patients. So I think it's impossible in the future not to consider these drugs for specific conditions involving renal and cardiac protection, which, by the way, are closely linked.
Okay, does, in all fairness, any panelists would like to comment on this last statement? And in another 5 minutes, we can conclude. There are a few, but we'll go through very quickly. Any other
When you
panelists?
use SGLT2 inhibitors, would you therefore not use the diuretics, or would it be in combination with the diuretic? What is the recommendation?
Can be
So,
given
I
in
mean,
combination. Can be
yeah.
given in combination. In the paper on a rather large database I published 5 years ago, I mean, it was clear that even when patients were under blockers of the renin-angiotensin system and diuretics and the two drugs together, SGLT2 were capable of reducing, in this case, it was ambulatory blood pressure.
As can I say?
Yes.
Yeah. As Dr. Venkatram was suggesting, see, SGLT2 inhibitors are wonderful drugs, but probably not antihypertensive agents as yet. They are very good drugs in diabetics. They're good drugs in heart failure, preserved ejection fraction. So there are large phenotypes of hypertension where SGLT2 inhibitors will count. But as such, as antihypertensive agents, they will obviously not be used. So they will be used in people who are diabetics, who have heart failure, preserved ejection fraction, and those who have heart failure with reduced ejection fraction. There's very minimal diuretic effect and blood pressure lowering effect that they cause. People have calculated it's to the tune of 3 millimeters of mercury, not very marked. And when we use it in acute heart failure patients who are admitted in CCUs, we are watchful of the fact that there will be some diuresis and we need to go down on the diuretics which are being used simultaneously.
Thank you, Gurpreet.
Venkata.
Yeah.
Can I make a comment?
Yeah, Reinhold, I'm coming to you. Next question. Then you can combine the comment.
I want to make a comment. I want to make a comment on the SGLT2. If you have time, if not, it's fine.
No, do it. Comment on SGLT2.
We should not. I think we are very clear in the guidelines. We should not confuse. The central figure you have seen the quarter with the blood pressure lowering drugs. Intentionally, the title of the figure is blood pressure lowering drugs, not antihypertensive drugs that are not approved. We have the core, the big ones, and we have additional drugs with specific indications. Clearly, SGLT2 inhibitors are blood pressure lowering drugs. They lower blood pressure, even in normotensive volunteers, have been shown by Michel Bonnier and others. But the indication are guideline-directed medical therapies in patients, as they are approved in patients with HFrEF, in patients with HFpEF, and in patients with CKD. But we should not dismiss that they are contributing to the blood pressure lowering effect.
Thank you, Reinhold. Just similar to the saga with earlier experience with statins, somewhat similar to it.
Yeah.
Which has been dismissed, however. There is in the Philly study, which is was a double-blind randomized study. Statin didn't have any blood pressure lowering effect on ambulatory blood pressure.
Reinhold, the next question is really towards you from Dr. Amit from Amravati, Maharashtra. The presence of LVH, either by EKG or by 2D, you mean to imply that one should be a little bit more cautious in lowering the blood pressure aggressively, whereas the general feeling is people with target organ damage, you have to be more aggressive. And there is a paradox here. Can you resolve it?
Yeah, I mean, probably, first of all, these are post-hoc data. So that we have to be cautious, but there are two important studies, very well done by experienced investigators from the value trial and the life trial, very carefully done. And at least when it comes to safety, I'm always cautious. You know, if we see a safety signal, we may execute some cautious. I mean, the question is the reason why they did it based on ECG, because in this 20,000 patients altogether, life and value, even more, you know, no echo was done, only a few, but the ECG was done in the life and value in all patients. And they looked at the LVH ECG-based diagnosis. So therefore, we are specific if we say this is ECG based on LVH, what they analyze. And we know if you see LVH in the ECG, the specificity is very high. We know that the sensitivity is not so high. So obviously, if available, we would like to have an echo in the patients these days, maybe in the future with smartphones. But I think we recommend that the ECG is a basis, is a baseline diagnostic procedure you should do in almost every patient if available. And if you see LVH in the patient, you may be cautious to lower the blood pressure below 130 millimeter mercury, which are post-hoc data showing that there might be an increased risk, as you have seen. I showed you the value trial. So, I mean, the general message is we can probably not, the recommendation to go below 130 millimeter mercury does not apply to all patients. We have to look into tolerability and also some specific phenotypes, and one is LVH. Probably does not apply to albuminuria, but probably to LVH.
Okay, thank you, Reynold. Thank you. Jamshed, can you comment on this seemingly, doctor, she's asking that whether one should be more gentle in treating hypertension in patients with LVH. Can you comment on it, Jamshed?
Yeah, I'm a little confused, to be honest, because I think at one stage we always say that those who have organ damage should be more aggressively treated. We also know from multiple studies, including the SPRINT trial, that very low blood pressures also are eventually good if the patient doesn't have any side effects. So now we seem to be again backtracking a little bit and saying don't lower the blood pressure too much. And there's a lot of emphasis even in the presentations that try not to get the blood pressure lower too much. So I am a little bit confused as to why we should not reduce the blood pressure in patients who have got organ damage and who are tolerating the low blood pressure, whether they're elderly or not. So I think I'm a little bit confused as to what the audience will take back as to what should be the correct level of blood pressure, as long as the patient is tolerating the blood pressure. And should not a blood pressure of 120 systolic be beneficial in the long run for patients as long as they don't have side effects? So I'm a little bit confused about these few things that have come up.
Dr. Subhash Manchanda has two questions. One, I think we should address it because he's asking, how low can diastolic blood pressure go? I don't know how low it can go, but how long will it allow it to go? Anybody from the faculty or from the chairpersons, how low should allow the diastolic blood pressure to go?
Yes, there is a specific reference to this issue in the guidelines, taking into account, however, that the studies that have concluded that we shouldn't go below a certain level of diastolic blood pressure are quite weak, post-hoc and weak. And so one concern of the guidelines was not to reach the conclusion that in order to preserve diastolic blood pressure, you should not lower systolic blood pressure, because the evidence that reduction of systolic blood pressure in isolated systolic hypertension is highly protective, is extremely strong. So if I remember the sentence is that to be cautious when diastolic blood pressure is already low, but privilege reduction in systolic blood pressure in people with systolic hypertension.
Especially in elderly patients, you often find diastolic pressures dropping down to 60.
Sure,
and the patient often asks us that question, should I reduce my medicines? And the answer should be no, look at the systolic and obviously don't worry too much about the diastolic, but there always is a limit beyond which there will be a problem.
Fully agree. Look at the systolic. Look at the systolic, as you, Dr. Dahal mentioned, but we should not confuse ourselves, if I may say so. You know, in 2018, we already, considered the SPRINT study and all the problems. This is not in our guidelines. The European guidelines is not a study that can guide us with regards to threshold and also to the targets. And we keep the targets, but, we have more or less similar. I mean, the take-home message was, down to 130, 80 to most patients. I think in reality, as Dr. Vanda has clearly shown, the problem in clinical practice, including India, is to have the patients controlled below 140/90 in the first place. And I think this is our major goal, to increase the number of patients treated below 140/90 or 140/80.
Okay. Now, very quickly, either Dr. Jadhav or Dr. Sharma, again from Dr. Manchanda, what is the current role of central aortic BP? I know that you have done some studies. Central aortic BP always gets honorable mention, but never gets an award. Just an honorable mention. So, can you comment on it, both of you, please?
Right. So let me quickly say that it stands where it is. It gets the honor, it doesn't get the award. It's too complicated to implement it into clinical practice. And of course, we don't have great outcome clinical trial data. So we stick to automated office blood pressure, home blood pressure, and as and when feasible, ambulatory blood pressure. So it's a great tool. It's very helpful to understand how the current anti-blood pressure lowering medications will help to reduce the events, but well, it still can't make it into the guideline as a decisive factor.
Yeah, I endorse saying. I think our own papers we looked at in a retrospective fashion, where the patients with coronary artery disease had higher hypertensive patients with coronary artery disease for the same amount of home blood pressure or the office blood pressure had different values of augmentation index if they had coronary artery disease. This was published in Indian Heart Journal. And then when we thought of inducing the same data in a prospective manner, the problem is that you cannot actually end up designing a multicentric study because it's the cost is limited not by the agents but the machine that could actually measure the central aortic pressure. So I think it's probably redundant in that sense, but I strongly believe in the concept that it's the central pressures that will determine the overall burden that will ensue rather than what you measure at the peripheries.
If I can add something, I think the guidelines are in line with what you just said. What is mentioned is that the concept is good because central blood pressure is the pressure which is seen by the vital organ. So no question about that, and no question about the importance of doing further research. We had the great experts in central blood pressure in the task force, and they, of course, were, knew the literature in detail, and they concluded that the data are not entirely univocal, but some important data do not show a clear incremental prognostic value or adding central blood pressure to peripheral blood pressure. And this was the reason why central blood pressure was described technically in one section, but in the end, the recommendation was still matter of research.
Another point, actually, in the guidelines, we have some chapters on different blood pressure phenotypes. And one is, for instance, isolated systolic hypertension, the young. And as a research tool, but also for diagnostic purposes, you may use, it's very important to use the central blood pressure, those patients, in young patients, to differentiate different phenotypes. Just another example, what we have tried to address in the guidelines.
Okay, very quickly, I will answer to Dr. Shami from Agra, whether one should be aggressive in treating hypertension from the beginning. Of course, hypertension, there is no point in waiting for too long. Just like a fracture or cancer, you don't gain any advantage by having a waiting period. You might as well treat hypertension when you diagnose hypertension. That is the best time to treat hypertension. And then we talked about again, somebody has asked about thiazide-like diuretics from the previous recommendations and the current low dosage. Dr. Paul Welton, who chaired the previous ACC AHA guidelines committee, did issue a statement that low dose chlorthalidone could be as good as the high doses that were used in the larger studies. I think pretty much we talked about BP targets with CKD. I think this is almost, this is the final question, Reinhold. BP targets in patients with CKD due to diabetes, not CKD or diabetes, CKD due to diabetes, and then I will ask Umapati Hegde to comment on it. Can you please answer?
Yeah, I think the general in CKD, but including the younger patients with definitely with diabetes is 130, 80 below. But you know, when we have the expert kidney guys in our task force, and as when it comes to the targets, it's still, we have still some gaps in evidence, unfortunately, you know. And Professor Manchard sometimes used the words, we rely on the Paleolithic trials, which is the MDRD and the ASK studies, you know. But if you look at the recent diabetic trials in also using SGLT2 and also the Fidelio and Figaro studies using finerenone, the achieved systolic blood pressure in the trials was in the area of 130, 132 millimeter mercury, actually. So that was, I think, the major. But we have a Accord study and other studies, you know, when we can use diabetes also in CKD studies in combination. So 130, 80.
Okay, and two more. Mangesh Tivaskar, elderly patient with atherosclerosis and isolated systolic hypertension. Mangesh, you do know that isolated systolic hypertension in the elderly is almost associated with atherosclerosis. Of course, they can have untreated hyperthyroidism, that is a separate issue. But there's no difference on treating atherosclerotic ISH versus non-atherosclerotic because they're all very, very similar. And then there is I don't think we can spend too much time. I was really surprised, and there was a question related to blood pressure measurement in children. I was, in fact, Guchepe, I asked you during that interview that I had with you, the amazing recommendation for frequent blood pressure measurement in children that was made in these guidelines. It was really amazing, really amazing.
Yes, yes. This was influenced very much by clinicians and investigators, pediatricians, you know, working in children, and so I can understand, you know, that somebody would be a bit more conservative about the frequency of the measurements in children and the age at which you should start making measurements. But I think, you know, that guidelines should have the courage of looking at a much better future in a way. They should try. And so this, from this point of view, I'm not against this recommendation.
Okay, then I think if you all permit, we can conclude this in another 2 minutes. Thanks for all the participation by the faculty and by the audience, by the chairpersons, and by the panelists. I do appreciate it. A lot of people have logged in at this time on a Sunday, and this was kind of an inaugural session for the ESH Comes to India series. The next program will be on October 29th at the same time, and we also have in November. And the details will be coming immediately after this meeting. I didn't want the audience to be confused, the agenda with this for October 29th, so that is the next one. So I think we had a good discussion on the new guidelines, the latest guidelines, latest as of now. So this is latest as of now. And the document should be published within a month, you think, Reinhold and Guchepe?
We hope that we hope that the final version goes online pretty soon, probably next week, and in print probably in the November issue of the journal.
Okay, so that's please look out for it, and if the society will allow, the PDF version of it. I hope that society will allow the permission, if the PDF can be made, Johnny, to be distributed to all the attendees of this.
It will be freely available online. It will be freely accessible online. It's hopefully next week, Giuseppe. We hope so, right?
Yes.
Yeah.
All right, then let me thank the ESH and our Indian faculty and the audience and the organizers and the technical team for all the help. I would like Mr. Johnny Edwin to give his closing remarks, and after he finishes his remarks, we can all sign off. Johnny?
Thank you, sir. Good afternoon, doctors. In fact, it's a heartfelt thanks from IPCA Laboratories to every one of you for your valuable presence on Sunday morning, especially to Dr. Ram for making this entire program a grand success with us. And of course, our heartfelt thanks to Dr. Jamshed Dalal, despite he was traveling and all, being present over here and accepting to chair the session for today. We are very grateful and thankful to Dr. Kamal Sharma as well as Dr. Uday Jadhav. Of course, Dr. Uday Jadhav sir is also traveling continuously and again making it his presence over here with his contribution. Thank you. And of course, Dr. Umapati Agade sir for his valuable presence and the contribution because of his busy schedule being in the hospital. We know the load and how busy he is. So for his valuable presence. It's a great honor to have Dr. Wonder as a speaker for today. In fact, Dr. Wonder sir was again traveling and busy, but when we had approached and he was very grateful looking into the eminent panelists and all, and he said, yes, I cannot miss out this program. So thank you, sir, for making it today. And we are very, very grateful to the ESH members over here for their valuable presence and accepting for bringing the ESH to India, Professor Manshia, Dr. Renault, Professor Grassi sir as well for their valuable contribution and accepting to talk as well. And of course, we had almost the same event being live casted as well as valuable audience present in more than 28 centers across the country today. As well as we had more than 2,500 doctors who are logged in as well and viewed this. So we are very, very grateful to the panelists who are available for their presence over there. Especially, I would like to thank a few names who are moderating the session in the respective places, like Dr. Professor Dr. Manchanda from Delhi, Dr. Ajay Kumar Sinha, and Dr. Vinit Kumar from Patna, Dr. Manoj Singh from Ludhiana, of course, where Dr. Wanda belongs to, and of course, Dr. A.P. Singh from Amritsar, Dr. Sudhir Kumar from Gorakhpur, Dr. Gopal Patli, Rajiv Gupta, and Dr. Alok Verma from Bhopal, Dr. Ramesh from Bangalore, Professor Arubdas Viswasa from Kolkata, Dr. S.P. Srivastava from Muzaffarpur, Dr. Rajiv Kishore Agra, Dr. Pankaj Jariwala from Hyderabad, Dr. Vasant Kumar Karnool, and of course, Dr. Akash, Dr. Kiran, and Dr. Rashish from Ahmedabad, Dr. Chatterjee and Dr. S. Chatterjee from Bardwan as well. Of course, there are a few other names due to short of time, just not mentioning all the names. It's a great honor to have you all. And of course, for all the audience valuable presence over there. And as Dr. Professor Ram mentioned, the next module of this next session of this would be on 29th October between 11 to 1, the same time. And we seek all your valuable presence during the same, as well as the third module will be also in the month of November on 26th. So our heartfelt thanks once again to each one and all for your valuable presence. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you, sir.
Thank you. Bye-bye.
Bye.